It's a real honour to welcome you all here on a lovely sunny day. Today we're going to be, hearing the outcomes of the out-of-hospital programme, but we're also here to really celebrate the launch of this report and the people who made it to this point and brought us all here. Getting to this point has taken years of pushing, dedication and advocacy from Michelle, from her team, from people on the front line, the practitioners who've helped support the development and delivery of these services, and also for people, our colleagues in DHSC and across in the Treasury for helping give us funding and get this support going for this initiative. And today we all have a really important role to play. Welcome, just come grab a seat, it's fine. Because it's taken quite a lot to get to this point, funding services, evaluating them, looking at the impact. But for some people in the room, it might feel like some of the new services we've managed to achieve are on a bit of a knife edge in terms of future sustainability. So today is about thinking about sustainability, and that's a role that we can all play today. We have so many people here who collectively are an absolute powerhouse. This is the community of advocating for homeless health, and we want to use all of you following this day to really help us move forward and sustain the development of out-of-hospital services. I think there's a bit of a truth that it's very hard to start something new without the data and the evidence. And I think we've always been challenged in the inclusion health space to really gather the data and the evidence. And I think that can sometimes be a bit of a wash to sort of not taking action. As you all know, we're seeing absolute increases in this size of this population. The needs are deepening with the cost of living crisis. So more than ever, we need to try and create the right solutions. You're going to hear that we have some great data, some great evidence today. And so we have a responsibility to act on it. And this has been such an innovative pilot. What you do in the absence of data is sometimes you drop something into the ocean and you see what happens and you evaluate the impact that it's having. It generates demand, but it also helps you see the demand that was completely invisible before you started. It helps you further understand the needs of the people that you're trying to meet. And so having an opportunity to sit back today, reflect on that learning and think about where we go from here is going to be really, really important. What this team have achieved is the ability to say, actually what we need are very specialist, distinct pathways of care for this population. And I think when you just look at the needs of the population, the needs for safe, trauma-informed, culturally competent, really supportive care, you see that actually there is a need for very specialised types of services. And yet this isn't specialist commissioning. This is something that's challenging to commission because the population's needs aren't well identified in the funding that the NHS has in terms of capitation formula, and certainly not in the rate of change that you see in terms of that population over a year. So getting towards good pathways that support hope, that support stability, that support lasting change, that are bespoke, that provide that kind of integrated with housing and other expertise support, that provide compassionate care, that really genuinely want to support this individual to make a strong recovery, that holds them beyond the service, that thinks about the connecting dots and enables people to go through pathways of care that genuinely support effective recovery. They might in some ways feel highly specialised, but they're very high on return. And you'll hear about some of that today, the impact that they can have, the financial return for the NHS as well. Though for many of the service providers, that's not their driving reason for being and why they're there. But there is huge returns to be gained in terms of health gain because the health needs are so high, the health impact you can have is phenomenal. So I want you to just listen today. I want you to challenge yourself to think about what's my role in the next step and ensuring that we can sustain the change that we've made so far and go beyond that, because what we've learned is what good looks like. And I think that's a real opportunity for us here in this room to think about how can we create world-class services for inclusion health populations, both in London and nationally, based on the learning that we've had from this report. So I'm not going to say any more than that, but I'm just going to hand over, she's going to go again, to...
So I know someone looking at the glass.
She's helping someone with their pathway into the room now. Everyone applause. You made it. Michelle, are you ready?
Yes.
Over to you.
Okay, well, a very big welcome to everybody. And I really just want to start off by saying a huge thank you to everybody in the room and everybody who helped with this study. It's been such a huge collaborative effort. And I think from the research team, wherever we went, we were just made to feel so welcome and supported. So thank you. And this really is kind of the culmination of what we're doing, but also we want a plan for next steps, a plan of what we're going to do next, because the problem is nowhere near solved. We've made a little bit of progress, but there is much to do. And what I really want to do in this presentation now is just talk about some of the key learning from the evaluation about what we know about mobilising and sustaining out-of-hospital care. Just very briefly, what is out-of-hospital care? Because I know there's some people here that are not familiar with the topic. And really, it's a range of services that support people to leave hospital quickly and safely. It includes the teams that work in the hospital, the discharge teams, and also, very importantly, short-term support in the community called step-down intermediate care. And that's really just providing a bridge between hospital and home for people who need a bit of support to get back on their feet. This whole policy has come to prominence because after COVID-19, Victoria changed all the hospital discharge operating models, all the policy was changed. And the idea that as soon as somebody was clinically optimised, they'd move out of hospital, they'd have time to get better and recover, and you would only do your assessments once people had maximised the recovery. The out-of-hospital care model programme came along because it was recognised that we needed services as well, not just for older people, but for people who were homeless. And prior to this evaluation, as a team, we'd done a lot of work to show these services were effective and cost-effective. So we'd done all the trials evidence that these services worked. But what we were seeing was on the ground, these services weren't being implemented routinely and people were being discharged to the street. The out-of-hospital care model programme, it brought 16 million of investment across 17 test sites in England. It included resources for improvement support, so the local government association went to test sites and helped them, and pathway, and lots of support for test sites. And then the evaluation, our team was commissioned to capture the learning. The programme ran from October 2021 until March 2023. And the last year, really, we've been spending time writing up the findings. So just to give you a flavour of what was that money, what was that 16 million used for in the test sites? Well, this is an example from Cornwall, and I know Colette's here, and I'm sure Cornwall won't mind me revealing their identity, because this was a very comprehensive, well-integrated model. And really, what the money was used for, so in the hospital, so I think Colette had been working in the hospital for about 12 years. This money came along and it brought some extra support for Colette. And Colette's role in the hospital is sorting people's housing, safeguarding and looking after people in the hospital. The money was also used for what's called Home First. So if somebody was going into temporary accommodation or a hotel, there'd be teams of support workers. 2 providers were commissioned, so it was covering a good patch of Cornwall. And this settling support was for 6 weeks for for people going home. For people who couldn't go home, the needs were a little bit higher. There was 3 step-down houses commissioned. One of these was a jewel in the crown, a fully accessible stair lifts, washrooms, an amazing facility, and that offered 15 beds. Underpinning that was a team of reablement workers, so housing support workers obviously don't wash and dress people, but if people needed washing and dressing and reablement, Cornwall commissioned a specialist team that was doing nothing other than working with people who'd experienced multiple exclusion homelessness. And that was required because the reablement teams working with older people didn't like to go into environments where there might be drugs and they would be giving these packages back. After about 6 weeks, 6 to 12 weeks, in theory, then care, people needed longer term care, then people moved over to adult social care. Now, this model in Cornwall was one of the most comprehensive and well-integrated models, but not all of the test sites achieved this. Quite a lot of the test sites, they invested in the homeless hospital teams, the pathway teams in the hospital, but in a lot of areas there was real mistrust of step-down pathway services for fear, not pathway 2 services, step-down houses, for fear that they would become silted up. So really this was a comprehensive model, but very few areas had the full pieces of the jigsaw. If we're a little bit critical about Cornwall's model, it was housing and care-led, so there was no clinical input. So in Cornwall, they didn't have something like a Mildmay hospital, where if people have got need for nursing for 24 hours nursing care, there wasn't that facility. They also didn't have a service in NCL here. There was a homeless intermediate care team was set up, and an advantage of that team with nurses, OTs, was going out into the community. They could work. The care homes were often reluctant to accept people who were homeless if they didn't have a address, and this extra homeless team worked to open up that tier. So really the big impact of the out-of-hospital care models programme, as it's allowed all this innovation, all these new ways of working and all this joint working together. And I think somebody summed it up nicely and they said, there's nothing like £1 million to bring people around the table. So it was a huge catalyst for integration and new ways of working. In terms of what were the facilitators of successful mobilisation, what mobilised things in all these areas, the first was ambitious planning and visionary leadership. In some areas there was like, it's another pot of short-term funding, we'll rebadge a few services, but we won't disturb the system. In other areas, again, to use Cornwall as the example, this planning had been on the table for a long time, and this money was seen as heaven sent, and it allowed rapid and fast movement of plans. They really believed in discharge to assess, and they really did it. The other big thing was appointing a skilled test site manager. In some areas, the test site manager was just a contract manager, and he or she did a bit of reporting to the Department of Health. But in the really good sites, and again, NCL, we saw the role was kind of head of system coordination. So if there was a problem in the system, the single system coordinators, they wouldn't just ignore it, they would try and tackle the issue. So here, to give an example again from Cornwall, there was a real problem getting social workers to come and do assessments of people leaving or people coming out of hospital, going into step down. So here the commissioners, they introduced what's called trusted assessment, and the housing providers in the step down, if they needed personal care for somebody, they contacted the providers directly. So that was trusted assessment. And in these good models, we see all this kind of system coordination. The most important thing really about that high level system coordination is it takes the pressure off frontline workers. It prevents frontline workers from having to advocate and fight on a day-to-day basis. So it was really protective. We saw in the programme a lot of issues. This brings me on to one of the main barriers. A lot of the barriers The main barrier was recruitment and retention. And there's really important learning for policymakers here who like have money and they throw it at a system to challenge an issue. But if you've not got the workforce, you can't set it up. And at the end of the first year of the out of hospital, everybody had a massive underspend because they couldn't staff these projects. They couldn't get things up and running. And that allowed a second year. That problem with workforce is well known. Again, we've got Victoria here in the wider intermediate. We know there is a problem with workforce, so shortage of social workers, therapy staff. So discharge to assess, you were coming out, and if you couldn't get an OT to come and look at your wheelchair, you were stuck, and it was kind of a warehousing. The other big sort of problem with the whole policy, or not the whole policy, is the housing shortages. It was very difficult to find properties that could be converted as a step-down property because disabled access, we couldn't find the properties. And then at the other end, just housing shortages meant the services did start to get silted up. And again, just to use Cornwall as an example, it started out as a 6-week service, but COVID, people moving from towns to coastal areas, it was a perfect storm and the delays really started to stack up. The other big issue, and I'm not going to go into too much detail about this slide, was around capacity. This is Michela's area, capacity, demand modelling and data. When it came to setting up the services, everybody was back of the envelope. You only had half an hour to do it, get your bids in. And everybody looked at the service in terms of what could be funded. And for some services, there was a huge shock when the level of the need started to reveal it. You've got 6 beds, but wow, the level of need was just huge. And I won't explain too much about this, but within D2A policy, we'd expect 50% of the general hospital population to be discharged with no care and support because you're fit and you can go home. Again, brilliant work by JJ and Caroline. They did an audit of 100 people's needs. And when you look at that, there was only one person out of 100 who just had a need for housing, who could just go out with no care and support. But what we saw in the out-of-hospital care models programme was that of 11,000 patients, 79% were discharged to a place or area that was unlikely to meet their needs. And so the big headline message is, great work, but we really haven't commissioned anywhere near enough intermediate care and out-of-hospital care. And if we do the fancy modelling, we estimate we need at least 2 and 3 times as much service. Again, just now, am I all right for time, just sort of, sorry? Are you timing, are we all right, yeah? So really, just to start summing things up, one of the things we did in the programme was to do we were everybody's nightmare of like, where is your quarterly monitoring forms? And thank you to everybody for filling those in, because what this did, it's given us a first pick, what was achieved at the end of the out-of-hospital care models programme. And this is a snapshot and audit. And the big key recommendation of everything now is we must not stop here. We've got a picture, and the key now is to know improvements, is we must kind of keep this going. So just very briefly, the idea of the audit was it should give commissioners a bit of good information. So what does it cost? What should you be paying per service user? So Michela, fantastic stuff, costs. We can see in the audit some of the challenges we've picked up. So we can see length of stay. Length of stay should be less than 6 weeks, 42 days. Got long length of stay in pathway 2 services. Again, we can see assessments, not enough care act assessments being done. And again, waiting times, the lack of intermediate care, we can see that because people are waiting 9 days. So that's a 9-day delayed discharge in hospital. So these are the kind of issues. However, on the right is the really positive things that was achieved. What this evaluation does is it adds to all the evidence we already have about out-of-hospital care. And we can say, we implemented it, baseline measures when people came in, when they left, and we can say it improves outcomes for the vast majority of people. And I know we've got people here today who will testify to that. Again, we did surveys of what did people think of out of hospital care. And again, the feedback from people using the service is amazing. People love these services. You're going to hear from Sarah in a bit. 93% saying they're treated with dignity and respect. And again, sleeping rough after discharge. All this work started back in 2012 when 70% of people were being discharged to the street. Where we've got intermediate care, it's not perfect, but the figures are a lot lower, of 4 and 5%. And as I say, really now the headline message is we must keep this going, because if we don't keep this going, we're going to kind of lose the momentum. And the big momentum is the message, there is much work to do. And the danger is, have services moving forward once the short-term funding ran out, have the services got extra funding, have they scaled up to meet need? And the answer is no. They've nearly all rolled back or finished. And the main problem underpinning this is due to the economic climate, due to austerity. There has been very little scope to routinise services and baseline budgets. They're continuing to rely on short-term funding. Better Care Fund is the main funder of out-of-hospital care. And when it came to sort of getting ongoing funding, the message from the programme team was, yes, go for Better Care Fund, but go for other sources, RSI, new programmes coming, changing futures. But the problem was that if you got a bit of RSI funding, you were no longer working, you might do a bit of out-of-hospital care, but you weren't really working on it. And by diversifying that funding, we saw a lot of watering down of the models, and they weren't as integrated as they were. Within the context of the BCF, the Better Care Fund, we saw little evidence in the programme that health inequalities were being addressed. The Better Care Fund was still focusing mainly on older people. And really, with the benefit of hindsight, if I had to do this over again, the thing I'd say is need for better joint working at the level of these high-level programmes. Out-of-care model should have connected with the Better Care Fund, and they should have worked more closely together. The Better Care Fund ring-fenced funding for out-of-hospital care for older people. And if there'd have been a little thing in there, but keep 1% of this for people who are homeless, it would have got services that step up. And it's not all bad news, because those that have worked, we're going to hear from Peter now, who worked to get things on the radar, have done well, but a lot of them, we lost them because there was that gap. I'm going to hand over now to you.
Right. So, good morning all. Excuse that, unaccustomed as I am to bendy microphones. Good morning, I'm Peter Moore. I'm the Programme Manager for the Oxfordshire's out-of-hospital care model. And I've been asked to talk a little bit about our step-down story and the history of the model in Oxfordshire. So I'll do that now. I've got some notes to accompany my slides. Let's see how we get on. Just keep an eye on time. Okay, so in Oxfordshire, we were very lucky. When the out-of-hospital programme came along in 2021, there was already step-down accommodation operating in Oxfordshire, delivered by Connection Support. That had come about via the trailblazer in homelessness prevention. So we weren't inventing anything new, we were building what was already there and already working. And that applied to some other elements of the model too. But the out-of-hospital programme allowed us to get an additional 6 beds to go with the 4 beds that were there. So we started off with 10 beds at the programme. We've now got 27, and we'll come on to that as we go through. Looking at the model, what is step-down care? You've heard from Michelle that it's a spell of recuperation and rest as you come out of hospital, maybe after a procedure, that ideally would last up to 42 days. For some of the people coming through step-down, that period of respite, catching your breath, and having someone take an interest in your life and helping you to make plans, it can be the first time they've had that in years. Just worth noting that. The Oxfordshire model was integrated from its very conception. So from the bid, which was put in by City Council, County Council, Social Care and Oxford Health, really lent itself to just working in a collaborative way. And I think we carried that forward in our model. How that looked for step down is that alongside the wonderful, and some of them are here today, the in-house support teams, we were able to put in clinical input to facilitate the D2A stuff that you've heard about earlier. So again, making sure that someone's needs and wants are assessed not in a hospital setting. That clinical input took the form of social workers, OTs, psychologists, and housing support. And they delivered that D2A, that wraparound holistic assessment of someone's needs, again, very much with the experts on the ground, our support team. But it really modelled that partnership working, and that was the important thing, to plan admissions, to plan risk management, and to bring these different perspectives together. So when you have a psychologist and a social worker talking about the Mental Capacity Act, you can get some really interesting third ways forward, which is what we found. So that's how our model looked from day one. The actual houses themselves, these are houses of multiple occupation. They're quite homely. A great effort is made to make them homely. They've got shared space, a shared lounge, shared dining room. And the main thing is they're not institutional. And when you compare that to some of the discrete choice evaluation feedback, essentially talking to people who use the services about what they want, that very much comes through. Again, part of the model, we were very lucky in Oxford again to have the Lived Experience Advisory Forum that we could work with, who carried out the qualitative evaluation of our step-down model, and that was invaluable because it was an honest conversation that really told us what people wanted, and we did make changes to reflect that. So the homely, it's a period, we talk about having that shared space, and some areas chose not to or didn't have that. One thing we found that did do was the opportunity to engage in, for want of a better word, this isn't the right phrase, but sort of life skills support and doing that sort of transitional support. So if somebody spent a long time, perhaps particularly in mental health hospitals, where, by the way, 50% of our step-down admissions came from, it can be very intimidating to have the idea of a tenancy and to set up your utility bills and to try and get a mobile phone account and whatnot. So having that and cooking and engaging with other people in a less sort of lockdown way. So that 6-week spell of cooking together in the evening or working with the wonderful support team to do that and activities, and that, again, transitional life skill work, it's hugely valuable in this model. Some of the challenges we found, finding a property that was accessible. So the first property we found, all the accommodation was on the first floor. So we were having to turn people away who had some mobility issues perhaps. And in fact, we weren't getting the referrals after a while to that property because people knew it wouldn't be effective. So we found another property that had ground floor bedrooms and level access bathrooms, which was a boon. I've put neighbour engagement. There's a load of work. The connection team did a great job of building relationships with our neighbours from an early stage, really trying to overcome any fears they may have, apprehensions. And then as management, bless you, issues occurred down the line, you had that relationship and you could have a conversation with your neighbours. That was very important to bed them in. Other challenges, the short-term funding, we talked about it earlier. Yeah, recruitment and retention has always been a challenge when it's annual contracts. Something that wasn't touched on, maybe stakeholder commitment. What do I mean by that? If a service is on the surface going to be here for 12 months, it's very hard to get yourself positioned in the system because people may think, I have been told, do think, what's the point? You'll be here for a little bit, then you'll be gone. There's no point building on those relationships. So that was a big challenge that I suppose, particularly spent a lot of time doing that networking and reassuring that we weren't going anywhere. An example of how that looks is that initially it was quite hard to get some in-reach clinical support from, for example, the home treatment team or community mental health teams. And I think we've really overcome that. Which I could talk about all of this at length, but I'm mindful of time, so I'm going to move on. Other challenges we found is the complexity and risk of the people that we're supporting in step down has only increased. It's only grown, whether that's more and more complex discharges from mental health hospitals or people with no recourse to public funds. We are open as a service to all these people, and we are expecting, increasing the expectancy from our partners is that we accommodate this, but there is a knock-on effect to length of stay and at times to our occupancy, depending on the level of risk and complexity within the house. So that was the challenge, balancing that wanting to be open to everyone, wanting to be what our partners need us to be, and to be part of the solution, which we very much are, into hospital beds stagnating and being stilted up, but also having a safe, effective environment in a step-down house that is going to be conducive to people's recuperation and everything else that we know step-down delivers. Okay, so next slide. These are just some figures. I won't spend ages on this. You can see 214 discharges. This is just through step-down. I'd like to mention we have, step-down doesn't work without the embedded hospital staff. Our housing options officers, our embedded housing workers are very much part of it. And if you added their figures in to people who are discharged outside of step-down, it'd be many more hundred. But today's about step-down. For 2 years, our length of stay was perfect. It's really good, well within the target. It has gone up, and for the reasons I mentioned around the complexity and actually other parts of the system being completely congested. You can see that very few people return to rough sleeping. That's one person in that period. You can a little bit of figures around the prevalence of substance use and mental health diagnosis and dual diagnosis. Again, touching on some of the complexity we're asking our support workers to manage and work with and support. Most interestingly on this slide really is the hospital data. We were very lucky. I hope he's here today, Alex. Fully with consent, fully with data protection all in place, we were able to track people's use of hospital services 12 months before step down and 12 months after. And you can see that ED presentations were down by 56%, emergency admissions reduced in the 12 months after this, and elective engagement in treatment as an outpatient that's not being admitted went up massively, which is actually a good thing because people do have health conditions. Undoubtedly, there'll be other factors that deliver that, but that spell, going back to that spell, 6 weeks of having your needs planned and the conversations around, which may be the first time in years that's happened, and not being discharged to the street, is critical, I would argue. Okay, last slide. This is around the value. So the value of step down, yeah, I've got 5 minutes, that's cool. The numbers are relatively low. So homeless people coming through or out of hospital through step down, it's relatively low. And if you're trying to build a business case, which is pretty much all I do, it feels, you're not going to get anywhere with just the numbers. It's the quality of the interventions and the fact that they endure and they last. People who are experiencing homelessness, going through hospital, often have long stays in hospital. They're often the most complex and generate the most amount of work. The quality of and length of stay and generating capacity and flow through hospitals is fundamental to what step down's about. But it's not the only measure. It's not the only measure. The value that step down brings isn't just in that. It's long-term interventions that really do make a difference, life-changing differences. So let's talk about some of that. How we do that, so how we generate this value is as important as what we do, and I think it generates what we do. So the step-down team, and you'll see, if I stop talking at some point, some of the figures around satisfaction. Was I treated with respect? Was I involved in the decisions? Which again, may be the first time in a long time that people could answer in such a positive way. 90, 100%, very high. How people are treated with dignity and respect not only is the right thing to do, but it generates engagement, it generates trust. These are people who have for years faced multiple exclusions from many services and multiple inequalities of access to services. So how we work is very important, and it also generates quantitative and qualitative outcomes. So some of the life-changing outcomes that we can generate through step down are breaking cycles, perhaps decades long, of readmissions. I mean, just the other day, our colleagues in the mental health wards were telling me that people who go through step down, they really don't see them again. If they're discharged either as temporary accommodation or to a hotel, they often return to mental health wards. That's directly from the team leader of the inpatient social worker team. But through step down, they don't. You're moving on, often to stable, but always to appropriate home with care and support if needed. By stable, I mean, it's not always it's not always your ultimate home that you move on to from step down. So one of the reasons our length of stay has been quite good generally is that the team have been quite pragmatic. A spell in temporary accommodation might be appropriate and might be your step towards a permanent home, but if you have the right support going in, and with that step down period to continue recuperation. But it can be we've had great success of getting people into supported housing and other types where necessary. Other long-term life-changing outcomes around reconnecting with family and the community, entering employment, training and volunteering. I might let Sarah talk with more eloquence about that later. as an example. The value of step down is system wide. So we've in Oxfordshire practically eliminated people being discharged to the street. It just does not happen from hospitals. It will happen now and again, but it used to be very common. So again, speaking to the team leader of the local outreach team from St Mungo's, habitually people would turn up in a taxi down at either one of the hostels or the homeless service or to City Hall or to wherever the hospital could send them. And that just does not happen. People know to call Katie or Julia or any of the workers, and it's planned. It happens occasionally, but very, very, very infrequently. So eliminating that, the impact on healthcare, the benefits are multitudinous. Every of those that I've mentioned there can see the benefits. We've done some great work with London School of Economics on the financial impact of some of these benefits, and it really hits on police, on housing, on all the services I've put there. And one thing we're doing this year is looking at longer term outcomes. So how are people 12 months after step down? We've already got that great stuff on hospital use, but how is their housing going? How is their engagement, maybe with their details or other parts of the community? Are they still in employment? So we've actually got a small resource looking at that going forward. The last section, and I've got 2 minutes to do it, is people have asked how have we scaled up. So we've gone from 4 step down beds to 27. How are we still here? In that first year, there was a whole smorgasbord of funders, as you can see, RSI, COVID Management Fund, urgent and emergency care, and we're very, very grateful for all of those because it enabled us to carry on. In 23-25, we were able to access Better Care Fund and ICB, Integrated Care Board, Health Inequalities Funding, which secured us for 2 years. How we've done that, I think, partly by having a dedicated programme manager, which sounds a little cocky because that's me, but it could be just having one, having that role. Because in other sites, it was being done as on top of a day job. This is my day job. I spend too much of it having to fundraise, but it's my day job. And that programme manager has to be tenacious and has to persevere and never, ever, ever, ever give up on the idea that we're going to carry on. Robust data that stood up to scrutiny. Absolutely. I've mentioned earlier case studies that LSE works on us with. King's College did an interim evaluation of the model, bless them, before they were due to do the full evaluation, just to help us try and get some more money. And if you show, as we did, they did, that an 89% reduction in bed days and no out-of-county placements for mental health services after a few months of working without hospital care has hundreds of thousands of pounds of impact. That stood up to scrutiny, and it was, believe me, it was scrutinised. It wasn't just a quick slideshow like this. Showing the power of the stories, though. So you got all the data. I've said earlier that the figures will never do enough because the numbers are quite low. It's the life-changing stories, and again, you're going to hear a bit more later about that. But I'm pleased to say we're lucky. I think some of it's just dumb luck. The Better Care Fund team and the Integrated Care Board members, so Ian Bottomley and Dan Levison in Oxfordshire, were just receptive to it. I did have to knock long. It took a couple of months to get that first meeting, and with me badgering, but when they heard it, and when they came out and visited the step-down house, and they spoke to the people who'd gone through it, who said, this saved my life. I had spent, and I'm not going to tread on someone else's story, but it saved my life. They listened, and we were just lucky with that, I think. Things like the NICE guidelines coming out, they actually said, okay, there's evidence here. So having that hardline data, which I know Michela's going to come to, and where we are now is that we have funding until next March, and there are ongoing conversations about extending it beyond that because the Better Care Fund goes in 2-year packages. We've got a workshop looking at getting us in the baseline budgets going forward, which I'll be speaking to Michela and Michelle about supporting. And that's our story of where we are, and I've gone 2 minutes over, so apologies.
I keep Peter here with me. My name is Michela Tinelli. I'm based at London School of Economics, and I want Peter to stay. So, no. But,
I shall remain where I was.
yeah, yes. Because we have some exciting news. I'm very excited, by the way, to present you what I've done. It's been 3 years in the making, really, very, very hard work. Everybody in the room and the team and also LSE people in the front rows just cheering me before because it has been very, very hard. But we are so pleased to be in the room now and present you what we did for the out-of-hospital care model in terms of data approach and evaluation, but also to present you about our plan for the future and collaboration with Peter and hopefully you all, because we want to carry on. We don't want to stop here. We want to do more and more in terms of evaluation and auditing. So there's a big program in terms of care systems, very much disconnected, talking to each other and sharing information. This is what we try to tackle. Also the data collection and quality varying across localities, and this compromise standardization that is very, very much important to achieve better reporting. And then engaging also with stakeholders can be also some challenging at times. So the results really of all these problems are poor person outcomes and waste of money. So as part of the evaluation for the program, we wanted to support the HSC, the government, to design and implement a better audit framework. We wanted to boost in terms of economic and outcomes evaluation, production of good data, but also, as I said, find ways, smart ways to keep the audit, to keep the evaluation going, because we want to carry on long term. We see that this is the future. We want to help service provisions, evaluation and provision needs to go hands in hand. There's a lot around metrics, and I don't want to bother you too much now. There's more we can discuss later in the afternoon at LSE if you want to join us, and I will tell you a bit more in a minute. But there's a lot of information that we collected as part of the evaluation program to feedback to service providers and commissioning at different levels. So this is a bit about the development process, really, starting from data collection of information around individual patients, questionnaires, hospital statistic data, but also the individual localities. They provide us aggregated information. All the data, they came to LSE in an anonymized matter. We process them all, and we produce key output to feedback to localities, to commissioning groups, local level and national level, the learning. There is a lot, so Michelle already showed you something to picture the national view in terms of reporting of the national program and in a static visualization, let's say. But there is more that we did in collaboration with localities. So for those that provided good audit data, we reported back PowerPoint presentation with loads and loads of information that they shared with us, and we packaged them all in terms of health outcomes, economics, patient-reported experience measure. This is a slide borrowed from Peter's set, just to show the element in green what is proceeding well, and also adjustments that might be needed. But there is more in terms of case story, the power of case story we have heard from Peter, and other localities really they use this case story to pitch for more money. So where audit data were not available, still we wanted to help, and we looked at individual, what happened to them before approaching out of hospital care, also after, and see the economic consequences for public budget, not just from health, but also mental health, social care, housing, and criminal justice. You can see the switch from how much one individual cost before in terms of total annual public cost to the after. So this is the sort of exercises that we conducted for a number of localities. But where data were available in terms of NHS statistics, but also prospective for the broader public budgets, we did more in terms of economics, in terms of cost effectiveness, and I'm very happy to tell you a bit more later in the afternoon. But this is just to picture more in terms of impact and consequences. We went the extra mile in a way. We did more than expected. So not just static visualization, but also dynamic dashboarding, something that you can access online, and you can play better with data, you can filter, you can do all sorts of things that you want. And it was a good learning. So there is a lot that is now sitting on LSE web pages. You are very welcome to ask the team, email us, but also access via the LSE website yourselves. And you can play with the data, you can see the feeling of using this dashboarding. What happened is really that we wanted to help different set of stakeholders, so the data can be filtered applying different lenses, so you can support better strategic decision making on national but also local levels, as well as operational support for service providers like Peter that can use this data to save staff time and do much more with the resources. We have to know, though, that as part of the evaluation, we didn't have the luxury, unfortunately, to give time to the localities to play with the information, with the dashboarding live on the web pages. This is something, though, that we want to carry on doing because we tested with Peter, it's working very well, also with other localities, and we want to carry on. And so this is what we have now. We have more work underway in collaboration with Oxford, and we want to kind of use the learning as much as possible from what we did for the evaluation until now, but adapt the template and the processes to localities' needs and what they need to collect. So we want to work together to frame the data collection, the reporting process, and do more and more in terms of dynamic dashboarding, real-time evaluations, an opportunity really to make the difference. So there is the opportunity now with the support of LSC to do some testing. So we want, first of all, to build a partnership, work together, collect data, and do some testing. I try my time to have a few extra minutes. If it is okay, we want to give you a quick view of what is underway, and hopefully this will help to describe a bit better what we do. So we have, this is a mock of what we are in production, and there are different pages in this visualization online. By the way, this is the future. It's not what we did for the evaluation of the out-of-hospital care. Different slides and different visualization can be downloaded from the website ILSC. This is the future, the map that is in place to build the future interactive visualization. And Peter, maybe you can help me to navigate the data, because these are Peter data. And
some of it is genuine data,
yes,
some of it is ghost data to generate a little graph so you can see.
So here we are with a summary view of the key statistics to give you a nutshell of few.
And this is very much in design stage. This is version 2, and my long-suffering colleagues in the LSE team might keep coming back. Well, can we have this? Can we have that? So it may look slightly different as a summary, but if we have a look at patient flow, so people like Deb and myself as program managers and ops managers, it will be really helpful to have this just a click of a button. At the minute, it's a lot of manual work that goes on to generate this kind of stuff, to generate reports. It can be filtered according to which home you're looking at, which step-down house. It can be filtered from whether people have come out of mental health hospitals and which hospital, just to give a lot more sort of nuanced data, really, that we have to spend a lot of time generating. And we're planning to use this for service management, almost in real time, to help us manage these services, but perhaps more importantly, to look at capacity and strategic commissioning decisions.
Yeah, well, there is more and more that we can present in terms of outcomes, maybe.
Yeah, so it can be what we want it to be, really, and it's as good as the data that we collect. But the data we collect is really good. So that chart there is showing where people have come from before hospital and the type of accommodation they go into after hospital. Again, some of that is generated for the quality of, or for the purpose of having a graph. So that's what we're working on at the minute, and we're really looking for partners. Potential Oxford is the lead partner with LSE, but if other areas are interested in helping us put that together so that we can have something we can benchmark and we can get a bit of a national programme of learning, please come and speak to us today, either at this event or the follow-up one at LSE.
That's great. So, well, I might stop here, but there is more in terms of capacity calculating, predictive analytics, and we can link to other dashboards we did in the past for the out-of-hospital care model. But just to leave, really, you're very much welcome to follow us for the afternoon event. There will be more tea and coffees to stay together, some more chatting, and we can have more space to show you what we have been doing in terms of dashboarding. Also, if you cannot join us in the afternoon, please email us, join the hub. I think you should have now in your inboxes, just now my colleague emailed you all, you should have an invite to formally join our hub. And this is a way to keep you all updated, to share news, and to start the work together. So I hope to see you in the afternoon, and I hope to receive your emails in my inbox. Thank you. Thank you.
Thank you.
If I can just leave you.
Oh,
We
no.
don't have the time to show the video, so Peter is very pleased.
I'm very pleased.
But you will receive this YouTube link and have a go. It's quite nice video to give you a more of understanding of the dashboarding. Thank you.
Thank you so much. So I think what you heard there, while our lived experience group join us for the next bit, you know, what you've heard is that there is a significant impact as a result of these services. It's very rare that you hear about a 56% reduction in ED attendances in current times, isn't it? And I think there's something about, you know, the cost actually is very small. We're talking about a very small population. The price per head might be expensive, but, you know, from a kind of population total NHS spend cost, it's really small. So actually this is about prioritisation. You know, about how do we start to really prioritise within BCF, as we've heard in other places, you know, that we're actually going to ensure a continued road for these types of services, which are having a significant impact. And actually, this is a very short pilot. What a phenomenal achievement. 2 years, very short pilot. People have had to sort out premises, workforce, get something up and running. They've learned a huge amount about the model in that process. So optimising those services is where we really want to get to. Because that impact has been phenomenal. So well done. Thanks to our first speaker. Should we just give them a quick round of applause before we move on? And so now we have a lovely kind of session for you around lived experience. And I think this is where we really start to sort of see and hear about that impact in terms of people's lives. So over to you.
Right, today I'm going to be interviewing Sarah. Sarah was a service user for Step Down, and it's basically, you can go into much detail about your experience and where you was at one stage as you like. There's no pressure. It's all on you. Okay, so don't be nervous. You want to turn your chair around so it looks like. So if you want to turn your chair around so you think we're in Costa, it's fine. You know, so just bear with me and just follow my lead. Sorry, it's because I'm short. Well, the first question I'm going to ask you is, did you know about Step Down before you entered into the service?
No, not at all.
What, hadn't heard nothing?
No, not until, so basically, just over 2 years ago, I was airlifted to hospital because I'm an alcoholic. I am in recovery. And I had nowhere to go when I came out of hospital. My mum's an alcoholic, so I couldn't go back there. Because of my behaviour when I was drinking, my husband took a court order out against me, so I couldn't return to the house. So I literally had nowhere. So the embedded bed manager of the JR kind of done a referral to Step Down. But like I said, I hadn't heard anything about it.
So when you was in the hospital, what was you told about it?
That it was a house for people that were discharged from hospital that needed that extra support, given that kind of like that breathing space to kind of get their life back on track. That you were given, I forget how many days, was it about 40 days there? And that you'd get a support worker. They'd help you with whatever support you did need, whether it was like moving on to private accommodation, going back to your family, referring you to services that you needed. I mean, everyone that was in the house had different issues, so they kind of treated you as an individual and addressed that.
So, how did the Step Down service help you, and what made you change your life?
Well, do you know what? It was the relief. It was when I was told I had a bed there. The relief was just immense. You know, it was that fear of where am I going to go from here. I remember when I first got to the Step Down. I don't know where's Zinni. So when I first arrived, so Zinni was the first person there, and had all these bags, because everyone kept bringing all this stuff to hospital with me, and you know I'd been on a feeding tube because I had malnutrition, and so I had all these drinks, and I don't know, I think it was the nerves. It just made me just laugh. I just couldn't stop laughing. It was just, But she was very welcoming, and
So what made a difference then with the Step Downs?
so it gave me that space. It allowed me to kind of process what was going on in my life. Before, I've been in and out of hospital for getting on for 10 years, I think. I must have cost them thousands and thousands of pounds. So not just with, sort of the A&E, it's like, the scans, the blood tests, the being on the ward, it's, all of these things. So step down kind of gave me that break so that I wasn't just being discharged back to somewhere that wasn't safe for me, because before I'd either be going back to my mum's, and like I say, she's an alcoholic, or I'd be going back, sometimes they would discharge me to rehab, and at one point they actually put me into a care home on palliative care, because they actually said, you're a hopeless case. Yeah.
So where would you be there if step down never existed?
If I'm honest, I would be dead. Yeah, I think having that I think I was there probably about 5 weeks, but unless I'd have been given that kind of like, it was kind of like I was able to switch off from life for a bit and just concentrate on me and what I needed without having to worry about, sort of my husband, and it sounds heartless, but, with the pressure of the kids and things and my addiction, it gave me that time to concentrate on me. And I think step down kind of gave me that, it's like that solid foundation. And I think without that, then I wouldn't have been able to grow to be who I am today.
It's like when you turn your life around,
Yeah.
you started doing research with the participants and asking them questions.
Yeah.
What did they have to say about the service?
Oh, just praised it, absolutely praised it. I think when it got to the point where it was like, is there anything that you could change? When you have to kind of like pick a fault, I think they were kind of thinking, well, I haven't got any. And I said, well, it can be anything, even if it's something trivial. And they couldn't. I think one person eventually said, well, can I say the mattress wasn't very comfortable? But I think, the service from the staff, it was just, amazing. Yeah.
So if step down didn't exist, basically you're saying that you'd be dead.
Yeah.
And
yeah.
What did the other people that you interviewed, did they say the same thing about step down?
But they were saying they got the individual support that they needed. I mean, some of the interviews I did were people that were also in recovery, and they got the same kind of guidance, go to Turning Point, engage in the services and things. And I think it allows people to turn their lives around.
So where are you now at this stage in your life?
Oh, goodness, yeah. So it was, just over 2 years ago that I was discharged from hospital. In that time, So I'm now like two years into recovery. I managed to complete a diploma, which I didn't think I'd be able to do. I didn't tell anybody about it, only because I didn't think I'd be able to achieve it.
Can we just have an applause for the diploma?
So I didn't want to set myself up to fail, because I thought if I tell people, then I can't achieve it. So I done that. I'm in a women's support house at the moment. I'm actually going to be moving out a week on Friday, because me and my husband have been able to rebuild our relationship. So I'm going back home with the children, and I've done some volunteering at Aspire. I've done a peer mentoring course at Turning Point. I got the opportunity to be involved with LEAF, and I think it was from doing these out of hospital questionnaires when sort of Lucy said, do you want to kind of do like the questions with the other residents that are discharged? And I kind of jumped at the chance, and I kind of thought, oh my goodness, somebody kind of wants me to do something. And I'm really grateful for that. And I think it's just led on. And so I'm a case support worker now at the Gatehouse. And then one of the girls has just gone on maternity leave, so I'm the temporary operations manager there as well now. And I do some casual support work at O'Halloran House, which is like a homeless shelter. So life's good. Yeah.
I think Sarah deserves a big round of applause for him. And the other thing I just want to say is that step down, it's going to, step down changes so many lives. And if you don't have the right support, your life won't change. And with the right support, she's living proof. Same as me. That's it. Come on.
From that inspiring story to our expert panel. So we have a couple of people joining me now. Sam, I think you're coming, Victoria, and Bola. Yeah, hard act to follow. It is question time.
It's wanting to build a question time. I'll pretend.
Okay, well, so we're gonna sort of start with just a panel conversation. I don't know if we're gonna have time. Hopefully we'll have a bit of time at the end for questions from the floor as well. But I also hope you're all staying for lunch and networking, because I'm sure you've got lots of questions for the panel and want to find out more about the data tools that we've just heard about too. I'm going to start though, Sam, with you, because your story in this journey was basically making the stuff happen in the service providers, working with some of those frontline teams. And so can you just tell us a little bit about that? What were some of the kind of barriers and challenges to getting the results that we've just heard about?
So I suppose from an in-hospital perspective, I think it's really important to acknowledge the crisis in the NHS in general, and the fact that obviously we're looking at 100% bed occupancy, so it is very difficult to do the right thing. And also, I was just talking to my colleague about pilot services. There's money gets thrown out, and when I set up the the St Thomas's service, I started in September, and we didn't go live till January, and they'd spent time recruiting me. But a lot of these services have had to mobilise so quickly. I suppose I think it's a really, really difficult job, this. I mean, as we've just heard, it's not just somebody who's got a simple housing problem. Lots of people have got mental health problems, addiction, safeguarding issues and whatever. And it's really difficult to sort those out quickly in a hospital environment, even if, you get the referral on day one, which in most cases you don't. So to really be able to do the right thing is difficult. And a shout out to all the staff that I know that are here, that are in hospital teams, that work every day really hard to try and do the right thing by people. And I know how difficult it is. You need to be supreme advocates. You need to have all the legal literacy in the world, and sometimes you're still left not being able to do the right thing. So that is really, really difficult. In terms of what we need, well, the step down is exactly what you need, because obviously we can't sort these problems out in hospital. We need time and space to do that. We need data to prove that. But also I do think there is issues around integration in the hospital and ownership. So I think there are silos between addictions, mental health, safeguarding within the hospitals, and that handover to community. And I guess I worry about where these teams sit within the hospitals, because really I think it should be safeguarding. And just a shout out to all of, to Michelle, to Jess, to Michela, to Jo, to Stan, to all of you that have worked so hard on this, because you're not just working on the hospital discharge element, you are working on the safeguarding element, you're working on the mental capacity element, you've worked on it from all perspectives. And, we couldn't be as far forward as we are without you. So that's amazing. And thank you. And thank you for your story, because that's what lifts us up every single day. And the three of us were all teary all over there. You are extraordinary. So thank you. Yeah.
I had another question for you, but I'm going to give you a moment, and I'm going to go, because it was quite a moment, I'm going to go on to Victoria Higher. So you were part of this journey too, in that you supported us to get this whole pilot into place from DHC point of view, and support kind of the development of this as policy and where it goes from here. And I guess what you're hearing in the room is kind of questions about what's the sustainability question, and sort of what just your reflections really would be good on sort of what you've heard this morning, and how we sort of move forward and what next. Thanks.
Yeah, I mean, it's great to see when national policy comes to life. and really does make an impact on people's lives. Sometimes that feels very slow from a national perspective. So it's also super encouraging for me to be here as well. So thank you so much for the invite. Michelle and I have worked together for many years, and we worked together when Discharge to Assess was a piece of best practice guidance in the sidelines. And I was delighted when I came back from maternity leave, I timed it very well at the beginning of the pandemic, that we turned that into national guidance, and there had been funding, short-term funding available for that. And that's where the pathways that you've been learning about as well, where that kind of originally came from. And so obviously Discharge to Assess, to put people in the right place for their recovery, has been a really central national policy for a number of years now. And the team that I work with, we then shifted a little bit into intermediate care, because we knew that actually the capacity of services for when people need to leave hospital was a really critical step in terms of improving that discharge experience and improving flow for the system. So last year we published the Intermediate Care Framework and an accompanying model for rehabilitation and reablement. And in that, we tried our best to cement some of the work that's been done, that we've heard about this morning, and talk about the importance of ensuring that when appropriate capacity is commissioned for people with intermediate care needs, that this ensures that there is prevention of exclusion and suboptimal care, particularly for people with particular living conditions, and including people experiencing homelessness or at risk of experiencing homelessness. And we try to put that in at the beginning. And I think that a lot of the work that we've heard about this morning, we see in the framework, we try to set out the importance of data right at the beginning in terms of improving demand and capacity planning, thinking about planning and commissioning the right capacity, but also thinking about how data is used on an operational day-to-day basis, like we've heard about that's happening in Oxford, because the importance of improving outcomes and looking at that on a day-to-day basis, and ensuring productivity of services to give people the best outcomes is really critical. And consideration of specialist intermediate care, that is in the framework as well. We've heard about the workforce constraints and issues which are not uncommon in this space, and there were a number of recommendations in that framework around that as well, but also the importance of that system coordination, which is one of the findings again in the report. That system coordination is really, really critical to pull all the pieces together, because I think what we've heard this morning is that this is a true example of when collaboration across sectors, across services, across teams really makes a difference. But you've got to have glue to bring all of that together, because we have a very complicated system of services that need to make a difference for these people. And so in the framework, we talk about care transfer hubs. They're called different things across the country, but that's sort of that hospital-based, multidisciplinary, multi-sector team, where the homeless in-reach teams obviously can be a real foundation to that working. And there was a big push in the framework around data quality as well. The importance of dashboards for day-to-day management, and ensuring that there is oversight of what's happening to people on a day-by-day basis. So I think that we've got some national guidance out there which really supports everything that's been done through this programme. And I hope that it can be leaned upon. And we've also got the original discharge to assess guidance from COVID has been rewritten multiple times, but it's now embedded in statutory guidance. And that also talks about the importance of ensuring that that people who experience homelessness or have a risk of homelessness should not be excluded from short-term recovery and support because of their housing status. So there's lots of things to hold on to support this work that is out there, and really hope that this and obviously the summary, the evaluation report can be a real springboard for sustainability in the future.
Thank you. And thank you for all your influencing in that as well, in sort of your role and within NHS England. So I guess I suppose one of the big opportunities we've heard about this morning was BCF was a good lever. Mm-hmm. Do you think ICS is using that opportunity nationally well enough? Is that something that people are using? Are we kind of confident that out of the BCF funding, people are prioritising inclusion health within that opportunity of funding? Yeah.
Sure. Well, I think it's all there to play for. Yeah. Systems are currently in the middle of that planning process. Planning guidance finally came out along with the BCF planning guidance, and in the directorate where I work, the national Better Care Fund team are right there in the same team. So we are working really closely together nationally to see how we can make sure that it doesn't look like things are happening separately. These are, we need to kind of complement each other. And I think there's enough levers in the BCF to promote work and services and programmes like this. But as you say, obviously in the economic climate, it is difficult, but I think there are enough levers there to be used across both the national policy, but also what the BCF planning requirements dictate as well.
Great. So we need to support you in that water cooler moment with your team to kind of make sure that gets done. Yeah, fantastic. Yeah. And then Bola, you've very successfully recently created an inclusion framework for the NHS, which is fabulous, and we're kind of starting to embed in our work in practice, sort of here in London. But you're now in DHSC.
I am.
So, what influence can you create, I suppose, in this new role, and what would you like to take from today, and in that challenge of managing that new role? But kind of what opportunities can you see for influencing how we move forward?
Yeah, no, really, really good question. Firstly, I've been really heartened by what I've heard today. I was particularly heartened by Peter's story about how he was able to influence his local ICB colleagues to get sustained funding, or at least an additional year's funding from the Health Inequalities money. And that's something that's so important, because our integrated care boards, they do have a duty to have regard to reducing inequalities. They've got to think about inequalities of access, inequalities of experience, and inequalities of outcome. And this is an agenda which really speaks to that duty. So in some ways, I can see why it was easy to get your decision makers around the table to have that conversation. I think the thing that I reflect on in this conversation and in many conversations is what a complex system we're working in. We've got to bring so many different players together to achieve the outcomes we want. And there's a really important thing, which is, when you ask people what were the critical success factors for a whole host of interventions, you hear different nuances. We've heard about the importance of having a workforce and the barriers of, a lack of a workforce to kind of mobilise services. But cross-cutting everything is leadership. And so I think for me, the one thing that we can do as a result of today is to take the report, is to take the evaluation findings, and to really make sure it's in the hands of local leaders who are making decisions, and that they understand what it is that they can do about it. So I think there's something about using our networks to spread the report across, directors of public health, who I think have got a really important role to play in this, across the NHS and our integrated care systems, and the networks of people who can make a difference. Because what it takes is, a small number of local leaders to get this agenda and to really commit to taking it forward. So I think that's something that we will definitely do, try and spread that report far and wide and really make sure that it can be leveraged. I think that, it really complements, we've just heard about the kind of intermediate care framework, but this report really complements the guidance that DHSE put out earlier on in the year around, discharge support for people experiencing homelessness. So I think that also gives us a hook to start those local conversations and make sure that people really understand what can be done. And then more broadly, I think there's an opportunity for us to just think about how do we just keep some energy going, keep a conversation going. So working with all of our partners at a national level who have got stake in this agenda to really keep the conversation going, so that there are more opportunities for more leaders to understand what they need to be doing.
Thank you. Thanks very much. So we're kind of getting close to sort of time. I'm just going to come back to you, Sam, if that's okay. So in terms of the what next for the teams that you've been supporting, what would you think they would sort of say were their next step challenges? What are the things they're facing now into the next year, things that we could think about supporting?
I mean, obviously the next steps for them are staying funded, aren't they? And that's why you need the data. And I mean, I can see how crushing that is. I think obviously champions in these systems are really, really important. And in my line here, I've got Peter and Liz, but you make a massive difference. So having those people is key. I do think Sarah, Debbie, people with lived experience do make there's no question. We've just delivered a health inequalities course in Salford, and people listen to Debbie again and again and again, and have gone out and made massive changes. So I think they are really key to keeping those services together. I think we need to appreciate our staff. We need to give them reflective practice. We need to give them clinical supervision. I think we need to give them a pat on the back, and we need to love them.
Can we just celebrate the staff?
And I think we also need to recognise and help people to see it's not that this problem is so much bigger than them. We've got 1 in 6 people, 1 in 6 young people with a mental health problem, massive increase in people accessing food banks, haven't we? So I know Dee is talking about trying to get a manifesto pledge on street discharge, but I think we do need to think about it in a much wider perspective and get our staff not to feel it's not, the failures of the system and not their failures, and they've been trying as hard as they can.
Okay, that's fine. So, I mean, we're kind of coming to an end, and I wanted to give Michelle a moment to sort of thank all the people who've contributed as well. But I guess what we've talked about a lot is sustainability, and it probably feels some people are we just sort of out with a begging bowl. We're not. We're out there with hard evidence, high impact, asking for not big sums in the context of the NHS, and we recognise that it's for all of us, the commissioners in the room, as much as it is for influencing at DHSC level and the NHSC level, it's about a team effort and a collective kind of advocacy for these services. What's great is that we now have good models that we can point at and say how they work. What you tend to try and do at that point is say, how do we scale that? And no one's used the word scaling today. How do we eliminate variation? How do we roll this out so it's a consistent way of delivering care that ticks the box very hard on nice guidelines, which we have too? So in the context of really challenging finances, I think, the bit that's sort of outside the door, because I see my ICS colleagues trying to balance that every day, absolutely challenging cuts in services, and really sort of, how do we say, well, actually, this is part of the solution. This is part of creating a more sustainable NHS. It's about part of addressing the financial challenges of the NHS, because it can have a significant impact. And perhaps the story that we heard, thank you, is one of the best that you can say in terms of, you know, what that impact can be in terms of people's lives. So yeah, let's try and talk about scaling, reducing the variation so we can get a consistent model now. We know what consistent good looks like. And let's champion a long-term goal. Let's stop talking about short-term pots of one-off money where the workforce have uncertainty, where, you know, they're frankly giving everything to this population. We should be doing better by them. Let's start talking about a 5-year transformation goal for the nation, where we get to world-class inclusion health services that is ring-fenced investment, that recognises the specialist nature and doesn't require an annual begging bowl. Okay. Thank you, panels.